post this webinar later in the next few days on the forums and everything else. So we're going to be talking tonight a little bit more about beautification and restoration of the lower face. I think it's a really popular topic in the last few months, probably the last years. I don't know what you think about this, Tris, but I think it was lips last year, and this year more and more patients have been asking about jawline.
Yeah, we generally see the industry kind of goes in trends, and it's about what's often picked up by the major press, and generally what the drug companies tend to pick up on a certain topic that they think their products are most suited to that particular year. And definitely we've seen in the last 12 months a focus on chin and jawline, both for beautification and for rejuvenation indications. And so I think this is the year, certainly from my perspective, that I've really developed my own knowledge and understanding in lower face treatments. And we've done a lot of teaching on that, and we can summarize a lot of the theoretical knowledge behind that on this webinar today.
So things that we're going to be covering really is we're going to be covering a bit of introduction to the lower face and areas that we're going to be looking at treating, an assessment of the lower face. So what are you looking for when you see your patient? Because I think what a lot of people struggle with from a speaking point of view is looking at a face, making that assessment, and deciding where is best to place your filler, which in most cases you have a limited supply of, whether that's budget, the patient, or your ability as well. So I think knowing kind of where you're going to be going with it is a really important step in that process. Next up, we're going to be talking about anatomy, some of the key anatomy that you need to know, the changes that occur with aging, and then also about beautification as well, and how placing filler in certain areas can help restore and rejuvenate the lower face. Next up here, we've got the different approaches we were talking about, the beautification or anti-aging, and then we're going to do a Q&A at the end. Now, it's really important when we do the Q&A that during this session, we've muted all of you. So it'd be good if you can write down any questions that you might have, and at the end, we'll have a really good live Q&A on the chat, and that usually works best when we're doing these Join.me webinar type series. So to start things off, I'm going to let Tris kick off with the first few slides.
Okay, sure. So what we tend to talk about, as we know and as we've taught from day one, we divide the face into 3 thirds: upper third, lower third, and middle third. And so we know that when we're talking about aesthetics, the upper third is the hairline to the glabella, the middle third is the glabella, the base of the nose, and which is called the subnasale, and then the lower third is defined as the subnasale down to the menton, which is the most inferior aspect of the mandible. What you can see in this diagram is you can see a surgical definition of the mid, lower, and lower third. And so it's just another way in which people have defined the lower third, which is the tragus to the corner of the mouth. Either way, generally, when we talk about the lower third, we're not talking about the lips. When we're talking about treatments, the lips generally sit in their own category in terms of educated aesthetics, and we're specifically referring to the chin and the jawline and the ascending ramus of the mandible.
Yeah, that's brilliant. And Tris, I just think a few people are struggling to hear at the moment, just with the audio. So if you can try and speak up a little bit, that'd be really, really good on the slide. So let's move on to the next slide. So this is what Tris was explaining. If you want to explain this a little bit more here, Tris, it's a bit of a diagram just to explain where the thirds are and how it relates to the lower face particularly.
Yeah, and what we also have in the lower third is what we call the local rule of thirds as well. So we can divide the lower third again into 3 thirds. And that's important because it changes depending on men and women. How's my volume, Marcus? Can you hear me?
I can hear you really well, actually. Yeah.
Okay. All right. So well, I'll just continue. And if anyone hasn't got this, I apologize, and you'll be able to catch up on this later. The lower rule of third essentially divides the lower third into 3 thirds again. And if you look at the stomion of the mouth, the opening of the mouth, that's the first division from the base of the nose to the opening of the mouth is the 1 third. And then the stomion of the mouth to the labiomental crease is what makes the second third in the lower third. And then finally the labiomental crease down to the base of the chin, the menton. And so we use those thirds. And I think the next slide is illustrating how that changes in men and women.
Brilliant. Okay, so next slide along, this is a really important diagram, and I think this is exactly what you're talking about, the difference between male and female trypts in regards to those proportions.
Yeah, and the summary here is essentially that men have a longer chin. So in general, the distance between the mouth and the chin is longer in men. So in ladies, you've got a nice 1/3 to 2/3 balance between the nose to the opening of the mouth and then the opening of the mouth to the base of the chin. In men, it's 1/4 upper lip and 3/4 mouth to chin. So generally men have a longer chin. It's acceptable and it's masculine to have a longer vertical height in your lower third from your mouth down to your chin.
Yeah, so skeletal proportions now, about the difference when we're looking at somebody getting this bigonial distance and the bizygomatic distance. What do you think about that, Tris?
So this is just from a study which looked at what generally, in terms of both male and female human anatomy, what is the correlation between the width in the midface and the lower face? And these are common craniofacial proportions that have been studied. And you look at the width between the two zygoma and the two corners of the mandible, known as the gonial angle. And generally, we notice that the distance between the gonium of the mandible is 30% less than the bizygomatic distance. And so what we teach is that actually there are various influences that affect those different distances. For example, those patients with mesenteric hypertrophy will have a wider bigonial distance. And that's something you can identify on examination. When you're doing your sequence of examination, you get to the lower third, look at the bigonial distance and identify whether there's a hypertrophic masseter. If it is, and it affects the ratio, and essentially it's almost as wide as the cheekbone, then a very obvious treatment is to denervate the masseters with botulinum toxin. Likewise, we can always add more projection onto the zygoma. But it's important to notice that what we don't want to do in a patient who has already got bony structure, forget muscle, bony structure on the mandible, if that's already relatively wide compared to the zygoma, we don't want to be treating the corner of the jaw in those patients, especially in ladies, because that can masculinize the face. And if you do choose to do that, perhaps for structure, to create some pillars of support, then you, at the same time, you ought to add projection to the zygoma laterally to keep that ratio in balance.
Brilliant. So when we're looking at the chin particularly, I think for me, whenever I teach lower face and the way we teach at Harley Academy, we talk about the chin quite a lot, because I think it's one of those key features in the lower face that can truly transform the way someone looks. And I like to think the chin in three anatomical planes. You know, you've got your pagonian on the most anterior surface, then your gnathian, and then your menton. And depending on where you're looking at revolumizing and where you're wanting that projection to come from, you can treat the chin truly in these three different planes. Whether you want more anterior projection, whether you want more inferior projection, and using the chin in those three planes works brilliant for me to give you that refinement that you can truly get in the chin.
Exactly. And again, these are new words for us to learn, and words that we start to pick up on when we're particularly studying the lower third. When we talk about the pagonian, it's essentially the most anterior aspect of the chin. And what we want to be talking about here is the soft tissue. Basically, where's the most anterior aspect of the soft tissue, which is the skin, of course. If you were to touch your chin on the front, that's your pagonian. And that is a particular landmark for assessing chin projection. And we can see that on the next slide, actually. On
the next slide.
Okay, guys. So I just want to whilst I've got this slide up, I think it's really important to mention, we want to make sure that if you just want to highlight on here, Marcus, the nasion, the start of the nose, is in the same vertical plane as the pagonian. And so what we want to do in our patients is in order to assess the chin, we're not
Where do you want?
line. You with me?
Yes.
Yep. We're not looking at Ricketts line, which is chin to nose, because that's how we assess lip projection, okay? In order to assess whether the chin is adequately projected, the pagonian is in a vertical plane with the nasion of the nose. And so we drop a vertical line down, and we can see there that is in a vertical plane. But in order to do that, the face itself has to be oriented in its horizontal plane. And so if you imagine if this chap here, if his chin was tucked all the way down, then obviously the chin would be posterior to the nasion. So in order to get a standardization for how we assess chins, we've got to make sure that there is a perfectly horizontal line between the infraorbital rim and the upper ear canal. And that's known as Frankfurt horizontal plane. So when I'm assessing my patients in their chin projection, number one, get their head in the right orientation, look at them from the side, and then draw a line down from the nasion down to the front of the chin. And here you can tell whether someone needs a bit more anterior projection or not. And if someone is actually over projected beyond that line, unfortunately, we don't have many solutions for that. That patient is probably a candidate for orthodontic surgery as opposed to non-surgical treatments in order to restore the harmony of their profile.
Brilliant. So now we've covered some of the key landmarks and looking at the lower face from those angles. We're going to talk a bit more about anatomy, which is really important to talk about when we're explaining treatment to determine what plane we're treating in, but more importantly than that, why we're treating in that plane to get the results that we're after. So, as we always teach, 5 layers to the structures of the face. And I think when we talk about this, it helps us really, whenever I do my treatments, I'm thinking, what layer am I in? Am I in layer 4 here? Am I in layer 2 here? And it really helps refine why we're doing things the way we are. So the 5 layers of the surface of skin we've got: skin, your superficial fat at layer 2. Layer 3 is your SMAS. So this is a deep fibromuscular layer that lays deep in the tissues and actually separates your superficial fat from your deep fat. And some of the muscles of expression, such as the orbicularis muscles, are encapsulated within the SMAS. And these are the muscles that actually, the SMAS is the same layer that plastic surgeons would use to actually lift and tether and tighten the lower face and jawline. Deeper than that, we've obviously got periosteum. So most of the treatments when we're thinking about your deep supraperiosteal injections, you're talking into layer 5, layer 4, with your deep cannula work sub-SMAS, which those of you that will know when you pop through that SMAS with a cannula, you know you're in layer 4 at that point. And this helps us identify where we're going to be treating when we talk about treatments in a second.
Exactly. And at this stage, it's probably worth noting that generally in the lower face, we are trying to avoid the deep blood vessels. The blood vessels tend to run deep in the lower face, and they traverse to become more superficially in the midface. And so one of our favorite planes in the jawline and chin is the subcutaneous layer 2 plane.
So, talking about a couple of key anatomical features, I think when a lot of people start treating the lower face, and I was no different, you're quite terrified, to be honest, because most of the anatomy we learn, particularly on when we first start out in aesthetics, is in the lower face. You know, we worry about the facial artery emerging over the mandible, we worry about things like the mental foramen, and it's important to really know your anatomy well when you're treating the lower face, because actually the zones and the specific areas we treat it in are very safe, providing we know what layer we're in and why. So the key features really in the lower face are your mental foramen, which are small holes on the front surface of the mandible that actually line up with the rest of the foramen in the face, your infraorbital as well. And from this, you've got a few small vessels that emerge, which we'll talk about in a second. Arterial supply-wise, we've got the facial artery, which, as you know, emerges from the anterior border of the masseter. So you can often get your patient, just to reassure yourself, and I did a lower face treatment today, and I still do it, get the patient to clench their teeth, feel the anterior border of the masseter, and just mark there where you can feel a small pulsation of the facial artery. And that reassures you when you're treating areas like the pre-jowl sulcus that you're well away from that kind of vascular supply. So Tris, do you want to talk about the next one? Next slide. To the maxillary?
Sure. Yeah, so alongside the facial artery, the other major vessel is the maxillary artery, one of the major branches of the external carotid. And what you'll notice, the maxillary artery emerges out of two foramina in the skull. As Marcus mentioned, we all know about the infraorbital foramen, medial to the mid-pupillary line. The same artery, the maxillary, has a branch coming out of the mental foramen, which is known as the mental artery. And that's fairly lateral on the chin, and of course, it's very deep. And so in terms of important blood vessels, we have our facial, if you just go back one slide, Marcus, we've got our facial artery and we've got our maxillary artery. And you'll see the facial artery ends up becoming the angular artery, which runs in layer 2. But before it does that, before it crosses the corner of the mouth, all of those vessels run deep in layer 4. And so if we're thinking about doing treatments in the jawline, you can see just based on where these blood vessels live, that generally the more superficial we are, the more safe we are.
Yeah, absolutely. And that's why in these areas that we're going to talk about, we're often talking about layer 2 work with a cannula, because we know we're not deep enough to affect where those vessels are going to be. So this is just talking about, yes, sorry, I saw you were saying but that's fine. So on this slide here, we have the facial artery that comes up. As you can see it emerging from the jawline. It's not the best picture, but it's a good one just to show you the very small vessels that run in this part of the face. And it's good to look at this, because actually it reassures you that the areas we're going to be looking at treating, and when I'm sure some of you guys have done jawlines before, the areas we're going to be treating into the when we talk about treatment today are actually, we're not putting a sharp needle anywhere near these structures. So on this diagram here, you can see the facial artery up emerging from the lower surface of the mandible. Coming up, you've got the labiomental artery at the bottom, the small mental artery that's emerging from the mental foramen, and then the inferior labial artery, which goes on to supply the lower lip. So when we talk about different kinds of treatments, lower face can be split into two key areas. You've got beautification treatments, which are on the rise, to be honest. There's a lot more popularity for them now, particularly Instagram has made this very, very popular. And you've got the anti-aging kind of treatments, and the aging treatment, should I say. So these are all the things that we treat essentially when we're talking about beautification. We're looking for chin projection, define gonial angles, treat the labiomental crease, essentially connecting the chin to the jawline and giving this jawline this subdermal enhancement. So using cannulas to run up and down the jawline and create that really razor sharp definition. And this is what a lot of your younger patients are after at the moment. And this is something that can be achieved really, really well using the techniques we're going to talk about today.
Yeah, and if I can just jump in there, Marcus, if your patient comes to you and they want this Instagram razor sharp jawline, I've had somebody describe it as like the corner of an iPhone style jawline. If someone wants that, and you notice that, if you just touch the corner of your jaw now, if you notice that someone doesn't already have the bone structure where there is essentially a projection of bone away from the neck, if there's almost a smooth transition from the lower cheek to the neck, then it doesn't matter how much filler you have, you will never create that sharp angle. And so often the photographs that you might see on Instagram are when the patient is jutting their neck to the side and really sticking out their corner. Some patients will come and they will already have that kind of bony anatomy that allows you to create even more definition. Perfect. Those are the ones you can treat, and it won't even take that much to really enhance it. But please be aware that the corner of the jaw is one of those areas where in some patients it is literally impossible to create definition, and I wasted a lot of filler and mismanaged a lot of expectations earlier in my career trying to create something that was actually physically impossible. And so we have to manage those expectations because a lot of our patients come to us after they've seen photographs of other people who have completely different morphology of their lower face to what they have.
I think you're absolutely right. I think managing expectations for jawlines is a massive thing, because so many people see so much stuff that's potentially Photoshopped, they see online, they expect them to have these amazing results off 2 mils, and the majority of patients won't ever get to that point where they're going to look like they do, that they see on the images. And I think expectations is so important throughout aesthetics, but particularly for this area of treatment here. Let's talk about aging. What happens as the skull ages, and how does that determine what we're going to do for treatment? So would you like to go through this one?
Yeah, sure. So this is a a well-known image from a paper by Mendelssohn, who was one of the first authors to talk about how the bony structures of the face change with aging. And it actually has more to it than you initially think. The size of the arrow indicates the degree to which there is bony resorption. And so generally we notice that we lose bony volume around our orbit, our piriform aperture widens in the midface, and significantly our maxilla recesses, all of those contributing to loss of structure and support, which is absolutely relevant to our lower face consultation, because the message here is in our rejuvenation patients, generally we want to start our work from the top down. The best jawline treatment you're going to ever do is in someone that you've already treated temples, cheeks, mid-face fully, because then you've created and you've actually addressed this bony volume loss to start with, and then you can really create a great result. But what happens in the mandible is we get recession of the mandible. And so as we lose the bony support, we get characteristic signs of aging in the lower face. We start to get some early jowling, and often the mentalis muscle, which is splintered down and forward by the forward bony mandible of the chin, loses its underlying support, and the mentalis muscle is responsible for lifting up the lower lip. And so as we lose that bone there, that muscle starts to rotate upwards, and that's what causes that crease. Often patients call it the witch's chin. It's a horrible term, but that's what causes it. And so the best way to treat that crease is, all we have to do, guys, it's really simple. When we're trying to rejuvenate the fillers, we just add volume where nature is taken away. And for the lower face, it's no different to the mid face. We're just adding deep revolumization where the bone has been lost.
And just that's great on to the next slide, really, which is talking about the approach. What is the best way to address these changes? Often with lower face, we're not sure where to start. Really, we should start from where we've lost it. And essentially that's starting with bone, working on those deep periosteal injections, moving on to soft tissue revolumization. So this is more layer 2 work. And then finally, we can consider neuromodulators as well, such as a bit of botulinum toxin in the mentalis muscle, just to stop that upward rotation that Tris was talking about. So, The chin. Where do we start with the chin and starting with bone? I think this slide really identifies all the areas that I typically start with when I'm thinking about the lower face. And essentially, I think when I was speaking to you the other day, Tris, you identified it really well. It's almost like building the towers of the bridge, and the bridge itself is the skin and the tissues in between the towers that we build with the deep periosteal injections. So really where I look at, and when I first mark up a patient, is thinking about the chin apex. So looking at the chin, we've got the Phagonian, Nathian and Menton to work with to get the kind of angle we want. Often what I will do is treat with, one injection, say 0.3, 0.4, probably in the midline for a patient. In some of my patients, if they've got a relatively narrow chin anyway, and we can work with that. You might disagree, Tris. I don't know which way, when the ways you treat, but that's how I would probably start. I would then mark out the pre-jowl sulcus. Again, deep periosteal injections into those areas of weakness, which you can just squeeze and feel where the pre-jowl starts. And then finally, I would treat onto the gonial angle, just to give that kind of definition in the gonial angles, but also to give a little bit of pullback and a bit of tethering. I don't know if you do the same sort of thing, Tris.
Yeah, so it's the same point. There really are no other points along the mandible that we should be injecting down onto bone. Particularly in the middle of the mandibular line, we know that the facial artery crosses there, so we'd never be treating deep in the middle of the jawline. Our targets are on the chin, and we're obviously down onto bone, and we're aspirating with all of these injections, guys. That's stage 1. I then like to look at the corner of the jaw, as Marcus said, and we mark up, essentially, we mark up the ascending ramus of the mandible and the line itself, and then we're just injecting down onto the front of the mandible, about 1 centimeter in from the corner.
You see
and finally, we're going to be treating the pre-jowl sulcus. And you can see that on your patients when they've got their inferior jowl just in front of it. If you squeeze the tissues, as you said, Marcus, you'll see a break in the skin. and that's often where exactly where you need to do your injections. When we're doing these bony injections, and in fact any treatment down on the jawline, initially when I was doing these for the first time, I made the mistake of actually treating on the base of the mandible, right along the shadow of the jawline. And what happens there is that you actually generally create inferior projection of the jawline. And when you do that, you don't create definition and you don't create shape. The objective should be to create forward projection, because that's what people see. And so all of my treatments are not along the line where the mandible curves underneath, but about 1 centimeter up from there on the front of the mandible, because that's how you get that anterior projection, and that's how you see the difference. If you're treating the corner of the jaw, it's not right in the corner. It's about 1 centimeter onto the front of the jaw. Same goes for the pre-jowl sulcus. Same goes for the chin.
Yeah, absolutely. And I don't know if you guys can see on the slides here, we've got a little pointer just to show you and to really show you that although it feels when you first start learning lower face that you're in a risky area, actually these points we're teaching you today are safe. There's no important structures where we're injecting. We're in a very safe plane. So we've got here onto the apex of the chin. The pre-jowl sulcus on this model is probably around here. You can always see where that's probably going to start. So site just about there, like Tris was mentioning. And then we're looking further on towards the gonal, which you can't really make out on here, but kind of these are your points. So from a bony point of injection, start your lower face treatments like this, with this kind of structure, these deep injections. And to be honest, with a good product such as Juvederm Volux, the new range from Juvederm, the Volux products, amazing, really, really good. You can almost create the jawline just with the deep injections, if I'm honest. So here, about here, and then onto the point as well. Okay, so we'll move on to the next slide, which is going to be the second layer, which is soft tissue revolumization. And one I think people focus on quite a lot because they feel that to do the jawline, you've got to be drawing the jawline with the cannula. But I think when you started treating jawlines, particularly with your deep injections, you'll realize that those towers of the bridge, as to say, create the best structure for your lower face. And this actually is more about the refinement, those fine little details. You've treated down onto layer 4, layer 5. This is more that layer 2 kind of treatment. And particularly when we're treating, it's a nice way just to finish things off and give that little kind of final touch. So for this, the areas that I treat with a cannula in layer 2, what I would normally do actually, and it's not identified all in this diagram, but what I would actually do is probably mark out whereabouts the jowl is, because this is an area we really do not want to be putting a heavy jawline type filler into, because if we do, we're going to make it worse and make it heavy. So I avoid the jowl area by marking it down, and that starts at the pre-jowl sulcus, and you'll see on the jawline roughly where that finishes. So let's say around this kind of area here. So what I would do to start with, that once I've done my bone injections, is make a cannula entry point, a 25G 50ml cannula about here actually, almost just in where the jowl is, because I'm not going to be injecting product into here. Then actually go in layer 2 subcutaneously along to the apex of the chin. So in layer 2 to the apex of the chin, and this is pretty tough, and it can be a bit uncomfortable for the patient, but essentially you should get the cannula till it's right into the apex of the chin. And at this point, you can actually leave a small bolus of product in this layer 2, which just can sometimes help give you that final tip on the chin that you can't quite get with the deep periostal injections. So this would be my first almost line that I would be kind of drawing on with the cannula. And I'd probably be using about, because I know you guys like to know a lot about the volumes you're probably roughly using, this is probably about 0.1 actually as a retrograde thread that I would leave in this point here, after leaving a small bolus at the chin tip there. So after I've done that on both sides, that's though, you're going over the pre-jowl sulcus in layer 2, you're kind of adding a bit of structure, a bit of support to it. Then what I'd like to do is, as it shows in this diagram, I'd actually make another point around here. So the other end of the jowl looking up backwards on the jawline. So starting here, again a 25G 50ml cannula, layer 2, entry point here, and run right along to the gonal angle. And then again, I go here, put my finger just on the back of the gonal angle so I can feel the cannula just busting up to my fingers up. Leave a small amount of product there, and then a nice retrograde thread. We could do another 0.1 here in most people, another 0.1. We don't want to add too much weight, just a bit of refinement there, and that's that part done. What I would say is the ramus injection going vertical here, I do it in some patients, but to be honest, I'd probably do this area I've talked about, so this area and then back up here, as you can see on the slide. I'd probably then think about this after I've done that on both sides. How do you feel about that, Tris, when you're doing treatments?
Yeah, so sometimes in some patients it can help just to help pull the tissues back, but the most valuable treatment is that the mandibular line posteriorly. And just to add there that if your injections down on the chin haven't softened the mentalis down, you can directly treat the labiomental crease again in layer 2. And we would just be passing a cannula along the crease. You can make one entry point and traverse all the way along the crease to treat both sides of it. And that further helps to squash down the mentalis muscle into its more youthful posture. The next slide is important, and I just wanted to show a little bit. This is your layer 2 fat, your subcutaneous fat. You can see you've got the large adipocytes, you've got the subcutaneous fat we can see here. This generally increases in volume as we age. So in certain parts of the face, and I want you to just remember 2 subcutaneous fat pads that always get heavier without exception with aging. One is the nasolabial fat pad, and the other is the inferior jowl fat pad. And so in the aging patient, if someone has heaviness in their jowl, this is the last place that you want to add volume subcutaneously. And the inferior jowl fat pad is bordered posteriorly, anteriorly, and anteriorly by 2 ligaments. So in the front, we have one of the strongest ligaments of the face, the mandibular ligament, and behind it, we have the mesenteric ligament. And you can feel these with your cannula as you're moving along the jawline. So in the aging patient, as you said, Marcus, we're generally trying to treat in front of the jowl to the chin, and we're trying to treat behind the jowl to the corner of the jaw. But what we're not doing is passing our cannula into the jowl. That's our no-go zone in the aging patients. And to be honest, for your younger patients with beautification, there is not much to be gained from adding any volume over there either. And so generally, I don't treat that area.
Yeah, and I would agree. Even in younger patients, I think it's an area which you can, if you really look at someone, make out where that's going to be, where the ligaments are just going to hammock that part of the jowl, and it's just not ideal to be putting that filler in. And I've seen patients that have come to me that have had product put in there, and it lasts quite a long time in that jowl fat pad, and really it can really destroy a good jawline actually. So we'll move on to the next slide now, Tris, if you're happy with that, and talk about neuromodulators. And this is something I think at Harley Academy we get a lot of questions about, neuromodulators in the lower face. It's an area, you've got to be slightly careful of. It's a bit more complex. You've got to be a lot more careful. You've got to really know your anatomy to know you're injecting in the right spots to ensure you don't get any asymmetry. And that particularly obviously applies to the DAOs. Most people, when I'm looking at jawline and chin treatments, my focus really is the mentalis, because this is that muscle that, as Chris spoke about earlier, as over age, we get bony reabsorption of the mandible, the mentalis loses its base and starts getting that upwards rotation, building that labiomental crease. We want to think about relaxing the mentalis so it doesn't cause, firstly, the upward rotation and the sort of strengthening of the crease and ruin all the good work we've done, but also it can cause that cobblestone appearance, the skin orange appearance on the surface of the chin itself. So mentalis works brilliantly with a little bit of botulinum toxin placed in it. As we put on the diagram, to my little pointer, but you can probably see. So 2 points of 3 units. And I think, to be honest, that's a pretty good starting point into the belly of the mentalis muscle itself. I don't really treat DAOs when I'm looking at the jawline in particular. It's more really my work that I do a little bit higher up. But I don't know about you, Tris, if you do much DAO work when you're doing jawlines and chins.
It's really just, I can actually soften the marionette lines, and but it mostly factors into your kind of perioral treatments to lift the corners of the mouth. So the mentalis muscle, we're doing deep injections, and they generally can follow the tracks that your filler injections went down onto bone. We're generally injecting down deep with your Botox. And then for the DAO muscles, the depressor angulioris muscles, we're doing those superficially because the muscles live just under the skin. And the best way to find those, if you stick out your bottom lip and make a kind of sad baby bottom lip, you can feel the muscles get firm right in the corners of the mouth. If you find the corner of the mouth 1 centimeter across, 1 centimeter down, that's roughly where you feel the muscle contract. And that's your landmark for injecting just under the skin. And we can do 3 units per side. and you'll notice in a couple of weeks a general lift to the corner of the mouth. It's worth saying that the reason why we've sequenced it like this is because we always want to know where the muscle is and what the muscle's contractility is like after we've revolumized. And this is something that you generally pick up on later in your career. You understand that the scaffolding around the face and the structure that we can create with fillers alters the muscle movement. It alters the length of each muscle and therefore how much they can contract. So often, a lot of the concerns that you might think you could jump in straight in with Botox, it's better to do your filler first, because sometimes they completely get treated just from doing the filler treatment. And that's because you're bringing the face back to a more youthful posture from revolumizing naturally. And so the muscles respond as if they were in a more youthful face. And therefore, your DAOs might be less contractile and your mentalis muscle might not be so upwards rotated because the filler has already done it. And that's why we've got a particular sequence for the lower face of bone, then soft tissue, and then Botox. But there is an exception, and that is if someone has got hypertrophic masseter muscles. Generally, if you've got, and that's my next slide, perfect. And so if someone has got an altered face shape because their masseter muscle is hypertrophied, then actually before we jump in with our fillers along the jawline, it's better to debulk the masseter muscles, and then we can see what's left with the bone and the soft tissue, and then we can actually start to create the jawline and the structure. And so we always assess for this before we start with our filler treatments.
So how do you treat masseter dentris? What's your approach to it? Because again, this is another one which I think people are quite scared of treating because it's we're not used to treatment. It's a little bit daunting. I get questions on a weekly basis from students unsure about it. So what's your approach?
Can you draw on this, Marcus, with your pointer?
No, but I can point on it, so talk to me.
Okay, so what we do is, the objective, guys, is to treat the deep and the superficial fibers of the masseter with Botox. A good starting dose, around 24 units per side. What's going to happen is the muscle is going to lose its ability to move as the neurotransmitters get blocked, and then it's going to shrink. So when you do Botox in the upper third, you're just going to get a result in 2 weeks. In the masseter, the result comes when the muscle's lost its bulk, and that requires another 2 weeks. So generally, 4 to 6 weeks is when your patients will see a reduction in size of their masseters. And then they'll come back in about 6 months. This 24-unit treatment might require a second top-up dose in another 4 to 6 weeks, by the way. And the landmarks for marking up where we're going to be going is, first of all, what do we want to try and avoid? What are the dangers of treating the masseter? Well, anteriorly, we've got the risorius muscle, which is a horizontal muscle from the corner of the mouth to the lateral skin on the lower face. And it's the muscle that's responsible for giving people a little dimple when they smile. And that inserts not far from the anterior border of the masseter. And so what we don't want to be is too close to the anterior border. So I would first of all recommend we're 1 centimeter backwards from the anterior border of the masseter. So you ask your patient to clench, find that border, and then be 1 centimeter backwards. That's your anterior landmark. Your superior landmark is designed to try and avoid inadvertent trauma to the parotid gland. And so if we draw a line from the tragus to the corner of the mouth, then we've created a superior border to our treatment. And then the rest is simple, guys. I just get my patients to contract and relax a few times. I find out where the muscle is strongest within that quadrant that I found. And I draw on between 4 and 6 little points with my white pencil of where I feel the most strength is within that safe zone, which is generally inferolateral in the masseter muscle. And then my treatments go deep into the muscle, and I'm injecting my 24 units across those various points. And I would take note to do a little bit of Botox in the deep fiber, and as I'm pulling out, I'll put almost a retrograde linear thread of Botox just to to make sure I hit those superficial fibers as well.
Otherwise, you
And
get this spasm, don't you? Because you can get a spasm with that if you're not careful, which is important to make sure that doesn't happen.
Yeah, if we treat just the deep fibers, then there can be some herniation of the superficial fibers, and we can actually that generally settles down on its own, to be honest. But yeah, we need to treat both layers of the muscle.
Yeah, brilliant. So I think this really is the last slide. It's one of our before and afters, actually, isn't it? From Guild Clinic, just to show you that low-based rejuvenation can be natural. This is more of an aging picture we showed you here to get rid of the jowl and just lift and strengthen things a little bit. I think really my key take homes from all of this really is to assess skeletal proportions first, make sure the patient's appropriate for jawline, set your expectations, because so many people with these types of treatments have very high expectations of what they're going to get from treatment. And it's an expensive treatment to offer. You're talking upwards of £500 to start treatment really, and up to over 1,000 really. And for when you start out practicing, there's a lot of pressure. As soon as the price goes up for you to get a result, the pressure goes up. If patients are paying £1,000, they're going to want to see £1,000 worth of results, whatever that means to them. So you need to make sure you're both on the same page of what you're able to achieve. And particularly with lower face treatments, I always think under-promising is the best way to go, and then over-delivering with your treatment is often what I find works best. It's one of those treatments where people are reluctant to start doing because multiple syringe treatments. It's something you will become more confident on, but it's one of those treatments that does need a few more mils, can be a bit more pressurizing for you. But as long as you set yourself up well, patient knows what to expect, you're in a good place to do a good job. One last thing to say about that, make sure you do their mid-face first in the majority of your patients, because that will make your life so much easier when you move on to the lower face.
Yeah.
Sequence of treatments, like I say, bone revolumization first, soft tissue next, neuromodulators last. And that's really that sequence. If you stick with that and you stick with the simple kind of approach that we've laid out this evening, it honestly is a brilliant treatment that can really make a massive difference to the way someone looks, particularly chins. Chins are one of those areas that's so neglected in aesthetics.
Yeah. And the jawline's quite greedy. It can really use up a lot of filler. Don't be surprised if you need to quote 3 mils per treatment. And that's because you're treating quite an extensive area. If you're trying to really change the form of someone's lower face, you need a good amount of product. And there's no avoiding that, unfortunately. The patients will have to be able to pay for it.
So that's the slide deck for this evening, guys. We've been about 50 minutes. A couple before and after for you to have a look at. The one on the left is actually 2 mils of Volux. The one on the right is actually 4 mils of Volux. But as you can see, she had quite a chin that was quite recessive, so needed that to build out the chin and restructure and change. So let's move on to the questions now. So those of you that have been saving any questions for now is your time. Now I can't unfortunately open up the audio because all 49 of you are going to start speaking. It's going to be very difficult. So we'll just do it over the chat if that's all right. So please type your questions in and we'll go through them all. So the first one we've got here from viewer94, hello. We've got, how do you treat a pre-jowl sulcus?
Okay, Marcus, you go back one slide.
Of course. 1 second, let me just get that up for you. So one slide back here. This one.
And just highlight this patient's pre-jowl sulcus with your cursor.
Is this like a test?
Okay. And
yeah.
just to be really clear on this, we're treating the pre-jowl sulcus in 2 different planes. First of all, we're down onto the mandible on the periosteum, layer 5, and we're going to do an injection down onto bone. Remember, the facial artery is posterior to this, so we're not concerned about blood vessels in this area. This is okay to be down on bone. We're going to aspirate anyway, and we want to be treating the mandible just 1 centimeter up from the jawline itself, so on the front of the mandible. And then with my left hand, I'm squeezing with my thumb and index finger, and then injecting between that gap down onto bone. Maybe 0.2 mils is a good place. In this patient, I would do 0.2 mils, okay? And then once we've done all of our bony treatments, we're then going to move to the subcutaneous plane, and we're going to treat that same area connecting the chin to the rest of the jawline with a cannula, as Marcus said, using the same product. And that might require another 0.1 to 0.2. So we've done a sandwich of filler in 2 different planes to really connect that jawline together. But we have to start with the bone because the mandible is started to recede backwards in that area.
And to be honest, that's where you'll get your longevity from. Those deep injections are where you're going to get the time the filler should last for out of it. Doing the subcutaneous planes, it looks great. It's not that long-lived compared to the deep injection site. So it is better to get those deep injection works done, get the jawline looking in good shape. And it is that refinement, that sandwich technique in layer 2 with the cannula. So that's pre-gel sulcus, really, as part of the jawline approach. If we've got any more questions, let's have a quick look.
Okay. What's the next question, Marcus?
So we've got, basically, you've got a hypertrophic mass on one side more than the other. Would you inject more toxin on one side rather than the other, if they grind on one side particularly?
Okay. My personal stance on that would be that, yes, if you can assess that someone has got definitively more muscle bulk on one side, then we should always be thinking, instead of just following protocols, we should be trying to tailor our dosage and treatment for any given presentation. And therefore, I would recommend using less on one side than the other.
Brilliant. Indeed, yeah, and I would agree with that, to be honest. I think if you can make that assessment and they truly have got one side that's quite a lot bigger than the other, I think it is worth treating one side stronger than the other. Like you would if someone had a slight lip asymmetry or anything like that, you would do the same for that, wouldn't you? Exactly. Okay. So we've got quite a few questions coming in here. So someone has said, I can't do them all here, but someone's asked, how do you mark mid-face? Well, for this presentation tonight, we're just doing lower face, so we will cover that and message us separately, and we can go through that with you if you want to go through that in a little bit more detail. Just can you do the assessment for chin again? I've got a few people private messaging me as well, and one person about doing the assessment of the chin dress.
Yeah, Mark, the video, is it possible to embed that video still, or are we too late for that?
Potentially, it could be quite difficult though for me to do that.
Okay. So we're going to. Would you like me to just repeat what we talk about with the assessment of the chin?
Yeah, I think in regards to fragment horizontal plane, it's probably what it's relating to.
Sure. Okay. So what we need to do is have a standardized approach and get our patients in a standardized plane so that we can assess chin projection. And so what we're going to do is make sure that there's a horizontal line between the ear canal. You can use the tragus as a landmark if you'd like, and the inferior orbital rim. Feel it on yourself, and you'll see that generally people's posture is facing more upwards. So when they come to you in clinic, you might need to ask them to gently lower their chin so that is in a perfectly horizontal line. Once they're in that plane, and it's a little uncomfortable, they'll be generally tilted down a little bit, but that is a craniofacial plane that is used to actually understand proportions and have a common language about proportions. Once they're in that position, you can have a look at the chin. And physiologically, and in terms of proportions, the chin is in a vertical line. The pagonian, the most anterior aspect of the chin, is in a vertical line with the start of the bony nose, which is known as the nasion. And so you can basically drop a vertical line down from the nose, and it should perfectly intersect with the chin, assuming they're in that horizontal plane that we found. And quite frequently, patients have a deficient chin. They don't have enough projection there. Perfect for filler treatments, for example. By the way, interesting point here, if someone's really concerned about their nose, they think they've got too much of a big nose, and you assess them like this, and you see that their chin isn't projected enough, often you don't need to treat the nose at all. All you have to do is increase the chin projection, and suddenly the facial the profile is in balance, and they are less concerned about their nose. But that's the sort of structure, that's the sequence to understand how to assess chin projection.
That's pretty interesting. There's another one we've got here as well. We've got quite a few. So we've got, what about metra LA? What about the mental artery and the mylohyoid artery? So
Right.
in all the we've been treating today, go on, Tris.
No. I think you have an answer. If you don't, I've got an answer. It's all good.
Well, I mean, so both these are branches of the inferior alveolar artery, which is a branch of the maxillary, and the inferior alveolar runs in the mandible itself and emerges from the mental foramen to become the mental artery. The mylohyoid artery is a branch of the inferior alveolar and actually drops inferiorly to supply the mylohyoid muscle. And so you're not really, where you're treating along the mandible itself, you're not at risk of any of these vessels. You know where the foramen is, and actually you're in a safe zone when you're going to be treating. Okay. And then, is it okay to treat with filler and toxin at the same time? Personally,
Absolutely.
I would do that. Yeah, absolutely. So just a couple of drops in it, but I would do your filler first, so you're not going to massage and move it around, and then your toxin at the end, like we would for any treatment. What do you think about MD codes? What do you think about MD codes, Tris?
I think they have their place. So there is. I can talk to you about the pros and the cons. The advantage of the MD code is that it's given a lot of practitioners a common language to be able to say, look, I've treated CK1 in this patient, in notes, in a handover. I know exactly what they mean, and that's great. But what it also does is that it actually simplifies things to a level where I think we stop using our brains. So what we talk about a lot is about practicing as a specialist. And that means understanding why we're doing what we're doing. And a lot of practitioners that are devout followers of the MD codes will be able to get nice results, but they won't be able to go off-piste. And I often think some of the best results I've gotten are when I've forgotten everything I've learned, and I've looked at my patient's individual presentation, and while still respecting their anatomy and the danger zones, I basically created a treatment plan using techniques that you couldn't find anywhere in the book. And that's because I've got an understanding of the fundamental principles of different layers of the face, different tissues of the face, and different products. The MD codes will remove that ability from your skill set. And so your practice will be almost on guide rails. I don't see the problem in that in your first year or two of practice, but I think as you get more experience, you will realize some of the limitations of that.
Brilliant. Okay. So, got a few questions. People wanting to see that chin assessment drawn out. It's quite difficult to draw it out. For the chin assessment you did, Tris, with the Frankfurt horizontal. Should we quickly run through it because there's a few people asking about it. So, shall I go back to that slide very quickly? And you talk through it because I've got the pointer control, haven't I? So I'm going to go through some pointing. Okay, so here you go. Let's start again. Just briefly cover it again for us, Tris. You talk about subnasally, the navion.
Yeah, Marcus, draw on the horizontal plane on this video pointer. Okay.
So, orbit.
Interior orbit, upper ear canal. This gentleman is in the horizontal plane. If he was tilted upwards or down, it needs to be horizontal with the floor. Okay, not with anything else.
In the correct hand hold position for Frankfurt horizontal plane, as you can see. I can't draw that straight, but that is straight. And then from the nasion to the point of the soft tissue pregonian should be a straight line to show that there's adequate projection. So in this case,
in line.
Exactly.
What I'm going to do is I'm going to include another diagram for this when we post it on the Facebook group. So it's really clearly illustrated how we can get that clear.
Yep.
A lot of people are asking, which is a very fair question, what more will be covered in the masterclass? To be honest, a lot of this theory is the fundamentals of what you'll learn on the masterclass. We just wanted to share it with you. But you will see, you'll do a lot of treatments, and you'll see some treatments as well. An alternative option is to do a one-to-one with us, where you can just book in an hour in clinic and treat your first jawline patient with us in clinic, and we can do that instead of a masterclass. If you've already seen this lecture that we've just done tonight, then that would be sufficient, I think, training for you.
Okay. So viewer 73 said, thanks, Marcus. Your voice projects more than Tristan's. Thank you very much, viewer 73. I think Tristan's calling in on his.
I've been speaking so loudly that my voice hurts, so I'm not sure what's going on.
Okay, here we go. Let's have a look. So there's another one here. In a 65-year-old with a jaw that practically disappears into the neck, can there be a benefit to doing jaw bolus injections, i.e. will they see a result? I think, so 65-year-old, you know, with these patients, you've got to set your expectations for what you're going to get out of treatment, and also set them for how much they're going to be spending here, because you're talking a 3 mil treatment really, aren't you? For a 65-year-old that wants a good result, you're probably talking a 3 mil treatment, if I'm honest. I think you can get a good result. Yeah, at least. I've had some really good results in 65-year-olds, but it's a really good result for them and what you're expected to get out of it for them. You know, it's not about getting them that perfectly chiseled jawline, but you're certainly going to help with their jowls. You're certainly going to help restructure their chin, and it will look better. Okay, someone said, can you do a mid-face version too, as this is very good? Of course we can. That's what
I'm replying. You've already done that, but we keep doing this. And I just want to share with you.
I did a face-to-face mid-face, though. It was not a webinar, which is quite nice because it's in the evening time to do it, yeah.
Yeah, just give us a number out of 10 as to how good this was, and we'll factor that in.
Maybe not publicly, though. Maybe not publicly. So let's have a look. What have we got here? Someone said, Liz has asked, what do you think about the use of a handheld Doppler ultrasound to identify vasculature for filler injection? Very, you know, not about tonight, but interesting question about aesthetics in general. What do you think about using a Doppler?
It's coming. There's portable high-resolution ultrasound devices that are coming onto the market. I reckon in a few years it will be quite common practice. But for now, it's not used. It's not taught. The technology isn't quite there. And generally, the incidence of vascular occlusions, once you're practicing and you know where the blood vessels run, etc., and you mitigate pretty much most of that risk just through knowing your stuff properly.
Yeah, absolutely. I agree with that. And then also, in a jaw, are you using the same product for layer 5 and layer 2? Well, you are. I mean, the new evolution of new products means you can get away with that. So, like we do one-to-one training with Volux. I use Volux deep to bone, use it subcutaneously. It's a brilliant product that can be used all over the place. More older filler products, sometimes you do struggle with using the deep fillers superficially because you can really see them. But, you know, new fillers you can. The same product you can use in both 5 and 2, or 4, 5, 2, yeah. Absolutely. So, guys, thanks so much for listening tonight. Thanks for tuning in. I hope you've enjoyed it and it's been useful. And I know there's been a few technical issues. Maybe we will change what system we use in the future. I would like to do a video. I think a video would be quite nice to me, interested to be able to talk through some of the more clinical aspects of treatments. And, you know, coming soon, we're going to have a lot more coming on with media production, be able to do live videos of treatments on sessions like this, actually watch a patient get treated as we commentate and talk. And that's kind of where we're going next. But I thank you so much for coming, and I hope you've enjoyed it. I hope you found it useful. We're always here for questions. Get on the Facebook group, email us, Marcus or Tristan at harleyacademy.com. We can answer your questions, whatever you might have. Any final words from you, Tris?
No, that was a pleasure. Thank you for having us. And as I said, get practicing lower face as soon as you can, because you'll find that it becomes a very core part of your arsenal for getting results in both younger and aging patients. And the sooner you get moving on this, the better.
Brilliant.
All right.
Thank you.
Thanks,
Have a good evening, and we'll see you soon.